Hello again, it's Kim Roth doing my nutrition case study for the week. This is week 3. Okay, so in case you haven't seen either of my other two, I'll just remind you where I am. I am at a 60-bed skilled nursing facility called Tulip Special Care. It specializes in the care of adults on ventilators or who are working on like weaning off of ventilators. Not every one of our patients is on one, just the majority. It's in Philadelphia, and it employs one RD and then me, the intern. Okay, so this week's case study is a check back to my first case study, the same patient, because a couple things have changed. Goes by MW, 52-year-old African-American male, height of 5'11". During my first case study, he had just come in and we had not gotten our own weight on him. He came in with an admitting weight from the hospital. And so we had him at, I want to say it was like 123 or something like that. But in reality, he weighs 104 pounds, which further lowers his BMI to even what we thought it was initially, which was really low. Initially, I thought it was 15.5. It has gone down to 14.5. He reports his usual body weight, has some stipulations from the next slide. You'll see at 190, an ideal body weight for him would be 160. So this is a similar slide from before, just reminding people of what he has been through. So so all this stuff is happening in the context of the white diagnosis. So that's like kind of like what he's dealing with chronically. So he has ALS, hence the difference between the usual body weight being 190 and him being down so low at this point. So since he was diagnosed with ALS, he has lost obviously a lot of weight. ALS, he's a functional quadriplegic. He has COPD and emphysema. Right now, he's ventilator dependent. He is anemic. The blue diagnoses were what brought him into the hospital initially. So he came in for a collapsed lung. He had developed pneumonia. It was in respiratory failure, hence the vent and things like that. So those diagnoses all still stand. Obviously, he doesn't have pneumonia currently, and his lung is healing, his collapsed lung is healing. But that was just kind of the chronic things that brought him in. Okay. So in the 2 weeks between the first case study and this check back, all of his lab values have changed, and honestly, pretty much everything has stabilized now, which is great. So I kept the same abnormal lab readings from last time and then showing you what they are now. So the N I'm using for normal. So his glucose was really high, but now it's down to 84, normal range. He has his CO2 is 31, which is normal. His creatinine is still low, but it is higher than it was before, which is great. And he's, his blood levels don't present as if he has anemia anymore, which is great. So those are both normal also. So that's good. He's still on the same medications. Again, it was just the top one was just for pain with a collapsed lung. That's kind of like as needed at this point. He's on an anticoagulant. He's on just electrolyte replenishments and things like that, and the vitamins on the bottom. And then whatever respiratory meds that kind of like go hand in hand with the ventilator. He's still on those as well, as they are trying to kind of wean him off of that and put him on a trach collar. Social history, not much has changed. I did add one thing at the bottom, but I'll run through these quickly in case you didn't see the first presentation. Used to be in musical production. He's single. He has a daughter. He lives with his mom, who I think helps with his care. He has a home health aide that visits 2 to 3 times a week. I put discharge planning on the bottom because his discharge planning is happening kind of like in the context of all of this stuff, right? So we had a discharge planning meeting late last week with his mom and his sister and one of his brothers, and kind of everyone kind of coming together and talking about, okay, now that he is stable, what does it look like for him to come home? His lifestyle history hasn't really changed. He does have a past nicotine use, alcohol use, drug use. When he was diagnosed with ALS in 2018 is kind of when things started to go downhill. But he did stop all those things once he was diagnosed. Nutritional focused physical exam. So he looks better than he looked 2 weeks ago. Unfortunately, he still looks bad. So you can still, I mean, obviously the weight loss is really severe. You can still see he has a ton of fat loss, a ton of muscle loss. Even just looking at his face, he looks malnourished. What is different is he has notably less edema, as per like the nursing notes, in his legs and things like that. He still has reduced grip strength. That's not really going to change much. He has ALS. That's not really something you can come back from well. Okay, and so I did update his PES statement. So the problem is still malnutrition. That is, visible for him. But now it says severe malnutrition in a setting of chronic disease related to advanced ALS and recent hospitalizations, as evidenced by a BMI of 14.5, significant reported weight loss of 39 pounds in between 6 and 9 months, which is 27%. Noted edema. Again, it's resolving, and severe loss of subcutaneous fat and muscle. So yes, the edema is resolving a little bit, but I mean, that really doesn't change the diagnosis of malnutrition. So I didn't want to just take it out because it was in here initially. Okay, and so intervention. Intervention is slightly different than last time. At least I'm giving more details than last time, which is great. So he still does enjoy eating. So he is on a mechanical soft diet during the day as he's able. He's not eating tons. And just because he's malnourished, because he has like all of these like COPD stuff that can require upwards of like 45 kcals per kilogram, we have him on like eating what he wants during the day, what he is able, and then we have him on a night tube feed of Gevity 1.5. It's going at 70 milliliters an hour for the 12 hours of the evening. 840 milliliters total volume, which gives him a total of 1,260 kcals, which just the night feeding alone is 26 kcals per kilogram. And he is taking in calories during the day too. So we're kind of monitoring that. And then as you can see on the bottom, monitoring evaluation, monitor intake and adjust his tube feeding and amount and rate. So, we're trying to kind of pay close enough attention to if we feel like he is not taking in enough PO, then we can kind of give him more as needed at night. If he is feeling like he can take in more during the day, which some days he does actually eat okay, then maybe we can start to talk about like backing that off at night. For him, since we are talking about discharge planning, it's looking like he will go home with a night tube feeding option, at least as per the last discharge meeting that we had last week. But I think that he'll do well on that, especially now that the acute stuff is kind of over. So we're happy about that. Oh, and stay tuned. And we'll see how he does in the coming weeks. Maybe he won't even be there because he'll be discharged. Okay, bye.